Hi, I'm Mary Brown, the Chief Nursing Officer and Team Leader for the Discharges before 2 p.m. A3. This was a really great team. It was an exciting group, and they're going to share all their great work with you today. The problem statement is that currently 57% of the medical surgical discharges occur after 2 p.m., which potentially can back up the emergency room and certainly contribute to patient dissatisfaction. This A3 was addressing one of the true north metrics of the organization, an organizational hospital goal of 44.5%.
So in order to understand how to change the process, we had to understand first how the process worked. The team mapped out the process. The yellow boxes show the process steps, and the pink ones show the undesirable effects, the UDIs. The green UDIs are the ones that we focused on. This graph shows how the process was performing prior to the start of our project. The percent shows how many patients were discharged before 2 p.m. We were running in the mid-40s with the fiscal year average at about 43%.
Our team's goal was to improve the discharge process. Our goal was to get 50% of our patients discharged by 2 p.m. in the fourth quarter. And up until that point, we were only at 43%.
One of the first UDIs that we looked at was admissions and discharges happening at the same time. It was hard for nurses to figure out, what do I do first? So we looked at the charge nurse role. We delved deeper into what's the process of charge nurse, and they're now taking a more active role in getting those discharges out. They know the admissions are coming, the staff nurse can concentrate on that admission, the charge nurse can then discharge that patient. So the next UDI we looked at was the discharge planning meeting, which was happening at 11 o'clock. Was too late in the day. Patients didn't know what time they were going to be leaving. We'd get the orders late. And as far as ancillary staff, dietary and PT seeing the patient, and social work, they didn't know who they should prioritize to get out early. So we moved the meeting to 8:30 and made it interdisciplinary. We got the physicians involved in it. We moved it out of a room, we put it in the nurses' station, and really focused on what's keeping this patient here for today. Can we get them out? And prioritizing what tests do they need right away. Do they need social work to see them right away? Does physical therapy need to see them?
So one of the UDIs that we recognized was that the secretaries were often getting backed up with orders. We noticed that there was a lack of the standard of work, and we decided to put one in place. We had people from our lean team watch us and notice, things that could be improved, which was helpful. And talking to the different secretaries, when we would start to put the standard work in place to see what they thought, if they could add anything to it, which they did. And that's basically how we came up with that. We had a list of ambulances. Some said ALS, some said BLS, but you really wouldn't know who really to call depending on the situation, if it was somebody that's just being transferred to a SNF or rehab, or if somebody was needing to go to one of the larger hospitals for emergency purposes. So the ambulance grid that I came up with, talking to the supervisors of the different companies, was able to tell me, well, they have more crews on or more, ambulances on, that they would be able to supply us with what our needs would be for the patients to be transferred.
One of the UDIs was that the physicians are waiting for test results prior to discharging the patients. We're working with radiology and consulting physicians to expedite the discharge process earlier in the day. This is still a work in progress.
So another UDI that we found was the secretaries were having a hard time making discharge appointments, follow-up appointments for the patients. They would have to call the health centers because when they looked in this computer system, the physicians were completely booked and it was taking up a lot of their time. Because of this, we have now created another A3 that is looking at this discharge process, and you will hear more about that at a later point.
Another one of the ODs that we looked at were the discharges to SNFs and rehabs that were happening late in the day. And one of the reasons was a lack of standard work. But we looked at several areas for this. One of the areas was the late discharge order from the physician. And now the physicians are coming to our morning meeting at 8:30, and they are informing us of any anticipated discharges, either for that day or the next day, and we're able to set these up earlier in the day. We also developed a nursing home capabilities list for the physicians that included most of the nursing homes in our area that we refer to, so the physicians do know what the capabilities are in each particular nursing home to help make their decision, especially on the weekends. Another project that we worked on was developing a downtime discharge summary for the physicians because we had delays in the past when the dictation system was down and we could not discharge patients until either very late in the day or the next day. So the physicians now have the capability of handwriting a discharge summary, and then the transcribed discharge summary will be forwarded to the facility when complete. So we are trying to start the discharges to these facilities in the morning. One of the ways that we are able to do this now that we were not able to do before is we had one reviewer that reviewed for 6 facilities. She was part-time and only coming to Wing in the afternoon. So we met with her manager and she rearranged her schedule to come to Wing in the morning, and we are able to discharge earlier to those 6 facilities. We also met with the administrator at Health South, which is our local acute rehab, and they also agreed to work with us on this project. We're also leaving a list for the secretary of anticipated facility discharges. The social worker and the secretary work very closely together to set up the times, and this is especially important on weekends when we try to set up our discharges on Friday, and then the secretary will inform the appropriate staff and arrange the transportation.
Before the change was implemented, we were at 34% of skilled nursing facility transfers before 2 p.m. So due to the changes that Jackie discussed previously, transfers were able to take place before 2 p.m., oftentimes in the morning. Because of this streamlining, the percentage has risen to a high of 71% in August. September had difficulties with a high percentage of managed care patients who often must wait for insurance approval, and often this can take up to 48 hours. We continue to monitor and work with our physicians to get some anticipated discharge days prior or early morning to undertake the approval process early in the day.
One of the things that the team asked us to do was to make a list on a daily basis of why discharges were leaving after 2 p.m. So every day when we had a discharge that left late, we would put them on a list on a chart visually in the nurses' station. We took all the barriers from our charts and we came together as a team and we put together what is called a Pareto chart. And after we plotted everything together, we found that the biggest issue was rides for patients to go home. The Pareto chart showed us that we needed to focus on the ride issue first. So we need to get to the root cause problem of why rides are not available in a timely manner. We decided to put up a fishbone diagram in the nurses' station to get everybody's feedback on why they think this is a problem. We brought it back and we all agreed that families really want to know 1 to 2 days in advance if their patient or loved one is going home, and that's not happening now. And we also realized there was no standard process in place. One of the countermeasures that we've been working on in regards to the delay in rides home is on admission, the nurse is trying to give the patient and the family notice of typical stay in the hospital, when they may be going home. We also try to get family members' rides or who they may want us to call, so we have those numbers on hand. We have just purchased new whiteboards that will put in an anticipated date of discharge. That will allow the patients and the families to have a little key on how the process may work with their admission. We also have come up with the hospitalist and the charge nurse at the end of the day to discuss potential discharges that may be going home in the morning. And that way we can talk to the patients and the patient's family the day before. This countermeasure is a work in progress, and we are writing it into our standard work.
We noticed with the rack that we have that orders were basically kind of just put in where they were and the charts were flagged, but that didn't always happen, and sometimes things would get a little bit delayed. So we decided to take the rack, make the bottom part of it for just regular orders, top part of it for, we divided and we did stat orders and for discharges. And that was just more of a cue for the docs to be like, hey, we have this order for you. It needs, patient needs to be discharged, or this one's a stat order. And we found that that really helped with getting patients home to the SNFs or to the rehabs before 2 o'clock.
The next OD we looked at was discharges weren't being communicated to housekeeping or the unit secretary. The hallway board communication, the dots were not being pulled down with the patient rooms to let housekeeping know that their patients were discharged. So we decided upon a different method and used what we call the ballerina board, which lists room numbers, discharge times, and cleaning times. So when the patient leaves now, the secretary writes down the discharge time. Housekeeping aides look at it first, and once the aides see that there has been a discharge, they strip the room, and then the housekeeping looks at the ballerina board and sees that it has been stripped and discharged patient, and we go in and clean.
So in July, we exceeded our goal. We were at 57%, and in August as well, 57%. And in September, we were at 46%. But if we had had 10 more discharges during that month, we would have hit 50%. But overall, we exceeded our goal, and we were at 53.5% for the fourth quarter.
The team was tracking daily results with the use of a visual management tool, which included red and green dots. The red dots were for any patient that was discharged after 2 p.m., and the green dots indicated a patient that left before 2 p.m. This was a great way to allow the team constant feedback. The slide you're looking at shows the process over time. The green line to the left of the slide shows the actual average before we started our improvements, which ran at 43%. And you can see with the changes that we made, post-improvements, our average was 53.5%. As Elaine mentioned, we did see a decrease in September, which is a little bit distressing for the team. So we regrouped and really started to look at what happened and how we could get those numbers back up. One of the first things we did was more consistent use of the barrier chart and a daily discussion around what's going on, what were the barriers, and how can we improve in each area.
I think that having the morning discharge planning meeting at 8:30 a.m. really got us on the right foot for the day and helped us out planning for our discharges.
One of the insights that we had in the A3 was actually doing a visual chart. People seem to respond to that, and then we put on there a white sheet saying, what are the barriers, so we could look at and see, they had ride issues, or they were waiting for test results. So we could then drill down and look more deeply at what are these barriers.
I think that we figured out what the bottleneck was, that part of the process was at the secretary level, that all the work was getting bottlenecked to her. And once we established a priority of what she should tackle first, I think that expedited the discharge process.
The process is more respectful of our patients and families because we are now giving them more notice regarding their discharge date, It allows for families to plan for the patient to return home or to go to a facility.
The nurses now have more of a direction on maybe how they'll plan their day. It also is more respectful of the patients and their families, letting them know that we want them to feel better and we want to get them back home.
To stay consistent with it, and to have everybody on board knowing that all of this work would have to be done, early, and that includes notification of families, that includes making sure that all the paperwork is done, transfer forms, everything done ahead of time in anticipation of a before 2 o'clock discharge.
I think the biggest challenge still is trying to coordinate it with nursing. What's a priority in the day? Is it discharging a patient? Is it admitting a patient? Or is it stat orders? And I still think that's always going to be something that we face a challenge with every day.
One of the biggest challenges was getting everybody there at the 8:30 meeting and getting the physicians to participate and understand how important it was for them to be there and have that interaction. One of the other challenges that we're continuously working on is the charge report, because not every nurse is there, so charge is speaking for them. So we're working on making that charge report more specific as to why is the patient still here, what went on during the night or the past 24 hours, so that the physician then has a dialogue at that time.
Working with the med-surg group, there are so many staff, plus we also were engaging the physicians, the environmental service people. There was so many staff to communicate all these changes. That was a very big challenge.
More chocolate.
One of the things that we need to keep working on is to keep everybody focused on what we're doing as standard work, showing them the positive sides of the discharge process that we're working on, and seeing that the patients are also happier and outside facilities are happier.
The constant feedback through the use of visual management is a great way to really sustain a project. I would like to expand that to other areas that they're monitoring on med-surg, so we can see on a daily basis how are we doing in the different initiatives.
I think just supporting each other and keeping the morale up and, letting us know when the numbers are coming up and just letting people know they're doing a good job and that, it is working. Definitely is working.
What, did I say that?
Yes, you did.
I'm waiting to discharge my patient.